Welcome to this episode of Orthodontics in Interview. It's my absolute pleasure to give you guys Richard Cousley. So, Richard Cousley has had a whole host of influence within orthodontics. I'm going to go through what he's achieved, but also I'm going to start off by describing how I met him recently at the Benefit Orthodontic meeting. Now, this was looking at innovation with use of miniscrews, and I saw Richard Cousley there, and he has his own implant system. We had a really good conversation about innovation, use of expansion, which is what Richard was there to see. When I came back, Richard then did the first digitally printed 3D expansion carried out in the UK. And it shows how innovative he has been, and he accumulates ideas from different places. So let me tell you about Richard. He's full-time in private practice since 2018 at the Priestgate Clinic in the UK in Peterborough. He's previously been a consultant in the UK at the Northwest Anglia Trust. He's also published multiple times in different facets. So the main thing for me is his mini implant textbook or clinical handbook. He sold over 10,000 copies, according to my research. It's been around since 2013. It's a great book looking at biomechanics and placement of implants. He developed the infinitas mini implant system in 2007. It's the most widely used in the UK. Over 40 peer-reviewed publications he's had, looking at both mini screws, looking at the use of 3D printing, orthodontic surgery and waferless printing, and wafers printed for them, in-house printing, a whole host of digital innovation he's been part of. He teaches as part of the Infinitas implant system, a previous associate editor for the Journal of Orthodontics. He's done pretty much everything that you can think about in orthodontics. So, Richard, it's my absolute pleasure to welcome you to the Orthodontics in Interview podcast. Thank you.
Pleasure. Thank you, Farooq. I'm glad to join a kind of a whole range of well-known speakers. I'm not sure if I'm kind of quite up on that level, but I'll give it a go.
I wanted to capture, Richard, is that we've had great conversations in the past of recent, and I think your innovation has been inspiring both to me. I also want to talk about the first time I actually met you, which you may not recall, was back in 2013. I was in my residency or my training. You're teaching a mini implant infinitas system. And what I really found inspiring from that course is that you spoke about intrusion using mini screws, but you spoke about 3 different techniques for it. And it showed to me that actually you were still innovating. You were thinking about different ideas, complications, solutions to them. And it's obvious to me that you've carried on innovating since. And you set me on a pathway as well, looking at the use of mini screws and not saying so one size fits all. I think that's where true innovator comes in, is they look at not only one side of the equation, they look at it from other users. Okay, users with experience, users without experience, how can we fit this process in? And I found that really inspiring. So I think you very much meet the bill for an innovator and somebody inspiring in orthodontics. But I wanted to find out about you in your journey. So what led you to the journey of innovation in orthodontics? And I would describe you as an early adopter in orthodontics. I think that's fair enough to say. But what's led you to that point in your career?
It's an interesting one because I don't necessarily think I'm that different from other orthodontic colleagues. Uh, in terms of skeletal anchorage, for instance, I started using initially the Straumann palatal implant system back in about 1999. So I think I was definitely one of the first people in the UK to try that out, and then used that for a few years, and that was very successful. But had kind of quite high, well, it's quite technique sensitive and quite high morbidity attached to it, particularly when refining the implant back out. And so when mini implants came out from the Far East, and I think I was one of the first. I attended the first UK course given by one of the sort of South Korean leaders back in about 2003, probably. And I was really skeptical about how these little kind of fiddly screws could bear up to orthodontic force loading. So I was pleasantly surprised when they did. And I suppose the innovation part came about, slightly inadvertently in the sense that I was trying out a couple of different systems at that stage, and had a conversation with a chap called David Verdes, who's now retired, but who set up DB Orthodontics in the UK as one of the main distributors. And we were discussing about what I saw as the kind of limitations of what was available at that time in the early days, and what would be the ideal kind of features as such. And he rang me from kind of like a sort of manufacturers conference in Germany and said, I can't get you this or that, but do you fancy designing your own? And that's how it came about. So we collaborated quite closely back in about 2006, 2007, and then along with an established sort of manufacturer in bone screw technology, and sort of came up with the infinitas system in back in 2007. So and it's to me there's a lot of features which are generalizable to other systems, but there are several unique features which I'm quite pleased with. So but as you mentioned earlier, it's all about not necessarily one size fits all. So it's about trying to offer solutions to different problems to different people, and then they can choose how they want to tackle that problem. That was the start of innovation.
And then you carried on the journey. So it's not as though you stopped at just the mini implants and it's been looking at 3D printing, 3D aligners. What kind of kept you going? Because I'm sure that took a lot of time from you to create an actual mini screw system, but you carried on with that journey. What propelled you to carry on finding other things in orthodontics?
I'm not sure, in the sense of it's probably my friends and family would say that I'm probably quite a critical person, but I think I'm probably critical of myself as well as of other people and other things. So it's just that lack of acceptance that there's only one way to do things, or that we keep doing what we're currently doing. So um, so to me, when intraoral scanning came out, um, well, I even started doing some digital work with orthodontic wafers before we got an intraoral scanner, several years before. So yeah, I I remember there was a really good technician that I worked with called John Pegg, who, and I don't mean this as any sort of as a slur or anything, but he was that sort of more senior technician, and I would have thought somebody at his age may not have adapted, or kind of looked in the future to see what was coming. And he told me years before it ever became reality that one day someone would put a camera around the inside of your mouth and scan things, and it would all be kind of virtual. And I sort of went, "No way, John." So John had a lot of talents that were very understated, and I love that in the sense of people who will think, right, how are we going to do things in the future, rather than looking back at how we've done things, always look forward. So that's probably why, like, I was very keen to start the digital journey, and then to see that through in terms of how many different applications you can get from what people assume is just a scan, or just a set of digital models. There's much more to it than just a set of models.
And I think when I came, thank you very much for inviting me to see your practice a couple of weeks ago. But what I saw was somebody who was really looking at how they could, it's almost defiance for convention. It's like, how can you start with this digital process and take it forwards rather than just adapting to digital? And I thought that was probably the most enriching thing I had from that experience, was that it's not about translating. It's about, well, how can you maximize the technology you have now? And I think that shows an outlook of, as you mentioned yourself, just looking forwards rather than looking, as you said, looking backwards. I wanted to ask you about the mini screw. So, of course, that's been a real key part of your orthodontic journey. But how often are you placing yourself mini screws? Is it something that happens on a daily basis, regular basis? Most patients have them. Is it infrequent?
It's an interesting one because I've never been high volume, because I've always thought that the most appropriate thing is to choose the right treatment for the right patient, and not be skewed in some ways just because you have a certain technique. Um, my usage has reduced compared with when I worked in the hospital system, because my caseload was much, was solely complex and nothing routine really. So it lent itself very much to a lot of mini implant usage. So in that sense, yes, I'm using fewer nowadays. So it might only be several patients a month who have kind of implants inserted. Um, but on the other hand, the kind of range of applications is increasing. So my usage, having almost gone through a bit of a dip, is starting to increase again, because, as you mentioned, things like 3D printed palatal expanders with bone anchorage. I mean, that I think there's a great future in that, but particularly, again, with the right patient, the right usage, rather than just randomly throwing them into everybody's mouth who comes along for expansion. So um, and the other thing for me, open bite correction. There is no turning the clock back. I just couldn't dream of saying to somebody that a maxillary osteotomy was their first line of treatment, um, compared with non-surgical correction. So so it's kind of probably sort of boiled down to kind of a kind of core grip, but a core grip that will distinctly benefit from the usage. Whereas on the other hand, I really enjoy what people would regard as conventional orthodontics, say like with twin block and fixed appliance cases. Um, I love the twin blocks are all digitally designed now in that sense. But yeah, I love regular sort of treatments, and just kind of I still do some orthodontic work, so I still enjoyed that as a sort of complex case with or without mini implant anchorage.
That's really interesting because my thoughts would be that actually tags and mini screws they've gone through perhaps some of their trending moments and perhaps on reducing it. But it's interesting how you're saying, well, actually for clinical application there's another application for it that we didn't think about initially, which is now where they're going to be used. So their journey is still developing and it's going up and down, and you're very much at the helm of that journey. I wanted to ask you about, we spoke about the UK a little bit there, but I wanted to kind of ask about adaptation or adoption of different appliances and how mini screws seem to have had a lower uptake within the UK if you compare it to contrasting markets, say in the US and the Far East, as you've mentioned. I'm interested in what your thoughts are, being based in the UK, as to perhaps why our usage of mini screws has been less or slower than it's been elsewhere in the international markets.
I think there's two sides to the kind of story almost. When I've been to the Far East, and certainly when I read a lot of um, Far Eastern literature, I mean, if you ever kind of browse through the Korean Journal of Orthodontics, which is fortunately published in English, um, there is an appetite for change and advancement. They're dynamic. It's almost like the culture wants to thrives on driving change and new things. And unfortunately, for my opinion, we lack that in the UK. I think it's partly sort of partly cultural in our clinical sense of being um, trying to be consistent and being seen to be safe. But and I think it stifles innovation. And I do have to say that I think the NHS stifles innovation because of how difficult, and this is from personal experience, how difficult it is to introduce new techniques and even subtle changes in process. The inertia and resistance, I think, is unfortunately getting worse. That we need to change our mindset and take control. So not jump on bandwagons of gimmicks, but actually look at things which have got some serious purpose to them, and think actually, okay, accept that when something's new, there's not going to be much of a research base, but you can still start using things in the knowledge that it may be evidence based, it may not be particularly evidence based, but you've got to start somewhere, and you can build in kind of safeguards, etc.
But you switched in 2018 from the NHS hospital sector into your relatively full-time private practice now, which is a successful practice, a beautiful place in Peterborough. Was this the driver that switched you from one sector to the other? Were there other things that pushed you or pulled you from the NHS to the private sector?
Um, it was a large part of it. I had a great set of colleagues, because I work closely with two maxillofacial surgeons, for instance, in the hospital sector, and I still work with several of them, doing some orthodontic patients with them, and that's still a very positive kind of association and interface. Um, it's but then the experience of trying to for instance, trying to introduce intraoral scanning into the hospital system um, was had such a negative impact on me. It was so draining to take something that was utterly logical and made complete business sense, even if you just looked at it purely from a financial and numbers perspective. It was a no-brainer in lots of senses, but the resistance um, to introducing something new was just the final straw for me. And yeah, so hence I thought, if I'm going to not necessarily innovate, but just be part of the new way of doing things. So kind of, for instance, scanning, cone beam, and a different, different workflow and a different perspective, then I had to get out and do it myself. So yeah, when it came to asking to buy a cone beam machine, I didn't have to fill in a huge business case and then wait 5 years for it to be bounced backwards and forwards. I had a conversation with my director, who happens to be my wife, and then said that this is what I want to buy, and that was the end of the conversation. So, I mean, so okay, I could be lucky in that sense, but um, yeah, that was why I had to leave. Really, it was the only way to continue my journey was to do it. Um,
I think you've got a good managing director there. I think my application would have been refused.
I wouldn't say we agree on everything, but
Okay. Um, so you mentioned about chromium CT, and I think that's an interesting topic in itself. Some people are quite polarized by the topic about increased radiation dose, and we should very much be avoiding or only on very minimalistic usage of it. Other people are very open to using it. I'm not just referring to the UK, but internationally, and actually think it should be a standard part of our clinical practice. So, when it comes to yourself, Richard, do you use CBCTs, chromium CT, routinely for your mini screws? Is that something that features as part of your clinical practice?
yeah, absolutely yes. I mean, again, I couldn't turn the clock back and not have 3D imaging. It's been to me, it's all about using it sensibly. So, for ectopic teeth, etc., and some more orthodontic prep. So it's all about using it in the right instances rather than thinking we've got a machine we need to scan everybody that walks through the door. So, and likewise in terms of for mini implant planning, it's subtle, but it has changed the goalposts. So I can think of, I mean, two groups of anchorage patients. So really, one is the intrusion cases for open bite, and being able to accurately visualize the morphology and the roots, say in the upper molar region for palatal alveolar insertion, and the 3D space, because essentially we've all, many of us have, many of us who are a bit older have been brought up looking at the world almost in a two-dimensional manner, with plain radiography. So we had to change the mindset to then think in 3 dimensions, and suddenly the three dimensional aspects opens up a whole different world. And mini implant insertion is very much a three-dimensional game. We've got to think about the depth and get more information about the shape and position of roots, etc. So somewhere like palatal alveolar sites, which are more difficult to physically access as well as to see what's going on, it's very valuable. I used to get, I mean, for open bite cases, the palatal alveolar success rate in my hands used to be about 90%. There was always the occasional case where a mini implant would fail, and I would think I couldn't work out why because I thought the insertion was fine. And in hindsight, now that with the switch over to integrating the cone beam in the planning, I do think that I didn't have a clear idea of what the roots and the morphology, etc., was. So occasionally, I've now taken the 3D scan and go, wow, what is that palatal root doing there? It shouldn't be, it's completely contrary to what I'd expect. So it's changed the game in that sense. The other group where it's changed things has been, say, hypodontia or cases requiring lower molar protraction, um, and I'd classically put a mini implant in, say, between the lower premolars or distal to the lower canine. But the bit of information that was always lacking, I was missing out on, was the alveolar depth. Now, I made certain assumptions about the alveolar depth, all based on old papers as well and anatomy, and then realized once I could start taking cone beams that I was completely wrong. and the alveolar depth is much more limited in these cases than I had assumed. So again, I changed my choice of mini implant, the dimensions for those cases, and focused more on rip divergence and then using a shorter, wider mini implant. And I do think the stability is better. So um, it's just to get in the right circumstances. It's very valuable. So I think we should be able to use all of the tools kind of at our disposal.
And I think that also shows, unfortunately or fortunately, Richard, how critical you are. Because I think most people take 90% success rates as really good and wouldn't think about it twice. Yet you're still trying to figure out why you missed out that 10%. It's too critical.
Yeah, no, I think, I mean,
I would.
this is anecdotal, but I've had very few since I started changing the planning to introduce cone beam and digital kind of combination. I suspect it's about 95% now for those sites. So I kind of go into it thinking it should be 100% or hoping for that, and there's still the occasional one that doesn't hold. But otherwise, yeah, I go into it thinking this should succeed, but we want to maximize success rates and sort of the kind of the whole clinical process wherever possible.
Just on this topic again, back on cone beam CTs, is that there's a line of companies now are starting to integrate CBCT data with the use of intraoral scans to be able to map hard tissue landmarks, utilizing both digital processes to increase the accuracy. Now, that sounds great from a diagnostic perspective. You get a lot more information. What's your opinion on that process of integrating CBCT data with aligner digital planning for aligner cases? Should we be doing that to be more accurate? Is the cost worth it, or should we be avoiding it? And is that too much use now? Is that we don't need that level of information, and actually we can exist without that diagnostic accuracy?
Um, I think, yeah, I'm quite skeptical about it. I think it's another it could be misused as an advertising sort of ploy, as in, oh, this is the latest thing we can now offer, but it doesn't mean that it should be used. Uh, to me, I enjoy using aligners, but again, the majority of the aligner cases, the movements aren't necessarily that complex. They're quite routine movements, and I can't personally see that why we can't get enough information from the orientation of the crowns, the clinical crowns, and why sort of the rich information would make that much of a difference. And certainly, I'm not aware of anything published in terms of outcome difference, and I suspect there won't be. Um, so I'm I think if we were looking at really complex movements, then possibly, but again, that would tend to be more done, in my hands. I like what I call kind of fusion orthodontics, where we do what I term as the hard work with a fixed appliance, then debond that relatively early and finish with aligners. And I really like that kind of workflow. And I think patients really like that as well. But in my mind, I've offered them the best of both worlds. But even for the complex movements, a lot of the time, three-dimensional radiography isn't indicated, isn't required over and above what we'll get from two-dimensional. So I would tend to think it would be a case-by-case basis and not just saying, "Oh, we've got a cone beam machine and we've got a scanner. Let's stick them together for aligner cases per se."
Hmm. That's really interesting. Again, when you think about innovators, and there's a presumption or early adopters that anything new would be adopted and taken up. But it's interesting. There's still that cognitive process through it. What is the gain? What is the loss from the process, rather than just going for it? And I think that's really insightful. Richard, a little bit about yourself. What is it you like to do with your time? What's your favorite hobby?
Um, yeah, kind of switching off in some ways because yeah, work does take up a lot of time. Yeah, I really like sort of I go sort of off road biking regularly with friends. We're going away for a long weekend quite soon, which will be up in the Peak District, and that will be kind of a combination of sort of full on sort of downhill concentration, sort of physically and mentally. And it's also, that to me is very like skiing, which I enjoy because then I find I'm so fully absorbed in the activity that I forget everything else, which is yeah, probably the whole purpose of getting out and doing something, having a hobby or an outdoor sort of activity. So yeah, so that's probably that kind of is really sort of physical and sociable at the same time. So I really enjoy that, and then sort of fill in with a bit of running and a bit of training sessions with friends. That so it's an occasional kind of tough mudder type obstacle course sort of activities and things. So it's just anything daft really that allows me to kind of completely switch off.
And touching on the idea of being able to full systems, digital systems to create your own attachments, your paper this year in the Journal of Orthodontics looks at a digital twin block, which you're using 3Shape aligner software from, which I thought was really innovative. And I came to your practice and saw them, and they looked wonderful. What was interesting is that Simon Graf also published a digital twin block, but interestingly, he used an acrylic component to his. Also using 3Shape, but the appliance software. So I kind of want to know, we've got these two digital twin block ideas coming forward, utilizing different materials, and what your thoughts are about the pros and cons. Or,
Um, it's a good question. I think both approaches are. I might be slightly controversial, but I'll say in my opinion, both approaches are vastly um, superior to the conventional twin block fabrication. So um, I've always, well, for about 20, 15 to 20 years, I've used a thermoformed lower part of the twin block with a conventional upper. Um, but to be able to do away with clasps and thick acrylic altogether, I think is a big plus. So um, I think we've probably fitted more than 80 of the kind of the new, what I describe as the new twin block, the digital twin block. And patients, kids will literally just pick it up and pop it straight in their mouth. It's almost intuitive from their point of view. It's very discreet, and that's why I kind of, at the moment where we are in current terms of resin technology, etc., I think we're at a turning point. But up until today, the thermoforming process to me has been the best way of making a kind of virtually invisible um, sort of low profile in terms of the bulk in the mouth appliance for patients. Um, I mean, Simon's sort of approach was very good, but I think you'd have to use laboratory orientated software for that design CAD CAM process. Uh, I think if where things will kind of converge almost is I have um, lots of patients that we fit a twin block and they come back and there's not a single crack in it. Um, Whereas I've got certain patients who come back and they absolutely trash things. And it's made me realize that there are a lot more teenagers who are parafunctioning and clenching, grinding, everything that we're not that aware of. And certainly, if you look at some of the sort of pediatric literature, then the prevalence is much higher than we realize. So of parafunction. So those are the patients who absolutely trash a kind of thin thermoformed appliance. And even if we kind of acrylic reinforce it, there's still the same offenders that have problems. So we get round that by replacing. They're very quick and simple to replace. In fact, we can tell somebody, if you have it starting to notice a crack, just email us and we'll get a new one made ready for you. So Simon's approach, having more of a kind of a 3D printed acrylic type um, twin block, would be more robust, but that equally comes at the cost of it possibly being a thicker appliance and needing kind of lab-based software. So where I think we're kind of will very quickly converge is direct print, using direct print aligner technology and resin, and producing twin blocks from that, where we can actually selectively reinforce certain kind of weak sites as such. So I think that is my fingers crossed that that's the way forward to get around the kind of the persistent breakage problems. And yeah, so I again, it's like other things. I wouldn't turn the clock back. I couldn't dream of handing a patient a conventional twin block with thick acrylic and clasps all over the place. I just, yeah, it wouldn't be on my radar. So, but we're only at the start of the journey. So I think there's always room for improvement. So that again, any technique should try and maximize the success rate as much as possible and not just accept it. Well, we're going to have failures and just leave it at that.
I think it's quite an exciting thing about the use of direct-to-print aligner materials and, as you mentioned, reinforcing components of the aligner. I think it's a really exciting time for aligners. So you've got a course coming up, which I believe, which is a 3D orthodontic course. It's
Well, we kind of, I mean, Lars is a great guy. He's really understated in terms of his abilities, and he's an early adopter. I mean, he got into 3D printing um, sort of significantly before I did. He's probably the first orthodontist in the UK that I know of who had a 3D printer. So right, whereas I didn't start 3D printing until early 2020, really. So yeah, Lars is an early adopter. He's a great. So I've known him from training days a long time ago, and he's always looking for the next new way of doing things and improving things. And he's very critical again in that sense. So yeah, so we sort of had a kind of casual conversation. I thought, well, why don't we set this up ourselves? And the idea is we want to take people who possibly have no 3D experiences and may not even be intraoral scanning yet. But whatever stage of the journey people are at, we can take them from scan through to fabricating their own retainer or appliance in that day. So it's how you go through that workflow, and also then the wide range of applications. So not just thinking, oh, this is about producing a digital model and maybe getting some measurements or information. It's about every possible use you can get from that digital file, and it even starts with kind of pre-treatment simulations to give to patients. So I find it's a spin-off. It's not why I started scanning, but um, to be able to show people before and after, realistic before and after representations of their treatment is highly beneficial, because it's the old cliche of a thousand, or a picture paints a thousand words. So if I can show them the actual changes, and I don't mean, dare I use the word clean check, I don't mean something that's unrealistic. I mean it needs to be orthodontically checked to make sure it's a proper representation of what you're trying to achieve. But yeah, so that's even the very first part of the digital workflow, sort of almost the gain from that digital workflow, and it follows through to the number of different appliances you can make from well, literally from a scan and software. And the 3D printing is, to me, was all, yeah, and the 3D printing was always the final part of the jigsaw. So that's that, so if people really want to get everything they can from the benefits of scanning, they need it to be 3D printed as well at the end.
Richard, just coming back to the final few questions now. It's looking at what's shaped you, I suppose, in orthodontics, and who are the lecturers and speakers that when you hear or see them speak, or I know they're going to speak, or there's a paper coming out with them, who's that you're looking out for? Who's on your radar when it comes to speakers and lecturers?
Yeah, it's a good question. There are lots of people who have sort of influenced me, and I think in the introduction to the first edition of my textbook, I hopefully gave due credit to to kind of other orthodontists, because I quoted the standing on the shoulders of others, kind of giants, um, which was Sir Isaac Newton's kind of. So yeah, to me, how I got to this point is only has only benefited from great innovators in the past. And I love, in terms of sort of mini implants, there've been people like you mentioned Bjorn Ludwig, who I think is truly, um, just deserves a huge amount of admiration, both for what he thinks and for how he thinks and what he can do with his hands as well. And other innovators like sort of Jason Copeland, say from the US, I always enjoy listening to him. There's been some great researchers. I mean, in terms of the amount of material published, say, on mini implants. I mean, but there are some serious scientists like Peter Bushang in the US. He's technically an anthropologist rather than an orthodontist, but his orthodontic research group have produced some really detailed and thoughtful publications. And it's, distinctly remember listening to him at an American conference a number of years ago where he presented work on high angle class 2 patients, and even at a relatively early stage with an evidence base very clearly stated, intrusion is the way to treat these patients, kind of compared with anything else. So, so I look out for, kind of giants like that. And it's interesting because I don't think I'm trying to mimic people like Bjorn and Jason Cope, but they have also done that sort of transition. They've between sort of say mini implants and anchorage focus, and now are very much 3D in kind of driven as well. But they haven't ditched the implant stuff. They're bringing it all together really. So again, we're not. I mean, Jason Cope runs a very successful uh, 3D planning and printing course in the US. So so a lot of it is just looking at how the other people do these things, have chats with them, and then not necessarily copy, but we should all, I think, still have learned from each other. And yeah, I've learned a lot from those guys.
That's amazing. That is amazing. And now, Richard, just bring over to the final question: is that what one piece of advice would you give to the orthodontists who are listening?
Ooh, I suppose just never be complacent. Never accept that how you do things is the only way to do something, or that it's unchangeable. So yeah, it's trying to get the balance between sort of frustration almost at kind of at things not progressing, but that on one side. But yeah, always kind of ask questions and think, well, is there a different way to do this? And I think um, actually, what part of a conversation that we had sort of in the past was that probably a lot, sort of a lot of our colleagues should really look to the international literature because there's a wealth of material and new ideas and new techniques being published, and it's across the world, and it's great just to learn from all of that, not necessarily adopt it all, but to see what's going on, to see what is possible, and then think, well, why can't we do that if it's the right thing? Yeah. So keep asking questions.
Amazing. Richard, thank you so much for joining me on Orthodontics in Interview podcast. I wish you the best of luck for your course happening in
Thank you.
September, and I look forward to seeing you again soon, my friend. Take good care.
Okay. Thanks for